thank you all for joining us today. We're here with GU Oncology now, and we're just finishing up day 3 of GU ASCO 2024, 20th year anniversary for GU ASCO, big year for us this year, and lots of really exciting data that got presented in Kidney Day, really across the entire spectrum from adjuvant, advanced disease. So really glad to have you all here with us. So let's just dive right in. Before we get into the data, let's just talk about Frontline. Where are we at right now? What is your practice? How do you think about the different options that we have from IO, TKI, and then the smattering of potential VEGF and observation? Katie, do you want to kick us off?
Yeah, wow, I think I'll love to hear what Dr. Tannir has to say, but I think continued data updates, Checkmate 9ER presented 55-month median follow-up data, and then Checkmate 214 with an 8-year survival data, and the only data showing an improvement over time in those good risk, favorable risk patients. So, if I think about IMDC criteria and I think about long survival and all these different factors that we can think about all these clinical trial data, but we have one person sitting in front of us. And so when I'm thinking about the patient, I'm trying to go for cure, recognizing that, of course, there's still a population of patients that maybe have a high visceral disease. So I still struggle with the upfront decision, but really I try to emphasize, is this a patient that if they progress, if primary progressive disease is the worst response, can I rescue them with a TKI? Then often I'm looking for that durable cure, that treatment-free survival effect. And then otherwise, I think, and it's, still probably, I don't know what you all would say, but a 20 to 30% patient population where I am worried they're really aggressive biology. And I may think that if I cover the spectrum of angiogenesis targeting and IO, that I might, get them through longer with that higher upfront ORR. But was so pleased to see the Checkmate 214 data presented. So,
Hans, what do you do right now currently? How do you help select patients? Who are you giving IO TKI to? Who do you give IO to?
Yeah, certainly. So I agree with Katie. The primary goal is cure. And I think, to be honest with you, if I take a step back, we are quite lucky. In renal cell carcinoma, we actually have immunotherapies that have response rates of 40% pure immunotherapy. We don't have that in the regular breast cancer or cold colorectal cancer. So we are lucky. To me, I think the regimen with the highest chance for best long-term outcome remains dual immune checkpoint inhibition with nivolumab, ipilimumab. That's my preferred regimen across patients. The main question that I ask, similar to what Katie was saying, is, do I need a VEGF TKI at this time? Am I worried about a symptomatic large disease burden where overt progressive disease will spell detrimental outcome for the patient? Then I may choose a PD-1 TKI regimen. But I would say the vast majority of my patients are candidates for nivolumab, ipilimumab. The other aspect that we don't talk about sometimes is you actually learn what actually happens. You get a sense of heterogeneity. You see if all the lesions are shrinking or 90% of the lesions, and you may consolidate, for example, with SBRT or with surgical resection. So it's my favorite first-line regimen. After that, patients by my definition are palliative, and I then go down the route of VEGF TKIs or similar therapies.
Yeah. How do you integrate IMDC?
I don't care about IMDC. I think in immunotherapy, it's not playing a major role anymore. Dr. Tannir, who's going to speak in a second, has shown us today that, in fact, for favorable risk patients, this is actually for long-term outcome probably the preferred regimen, quite frankly. And I think we need to rethink our approach in those patients.
Yeah. Dr. Tannir, what is your approach to Frontline?
I share the opinion and sentiment of Katie and Hans. There are patients who you look at them and you believe that because they have very high tumor burden, it's very symptomatic, and if you believe like you have one shot at goal, as some of us frequently say, you may say, well, this patient needs a quick debulking of their disease, and you may choose a TKI. Now, of course, there are 3 IO TKI regimens. The one regimen that I believe produces the fastest, most impressive tumor shrinkage would be lenvatinib plus pembrolizumab. And I am an immunophile, and like Hans and other colleagues in the field, we believe, the aim of treatment for any patient with cancer is cure. So even though for the vast majority of my patients, I choose nivolumab plus ipilimumab as first-line therapy and start the induction, there are some patients, and recently I did treat a patient with lenvatinib pembrolizumab who was severely symptomatic, and I was concerned that he may not have a chance, even 6 weeks later, to get a chance a second line. He was extremely symptomatic with cough, dyspnea, and he had extensive lung mets and mediastinal and hilar lymphadenopathy. So he responded to lenvatinib pembrolizumab. But the vast majority of patients, I'm able to give them nivo-ipi first. And the reason is because I'm not looking for instant gratification. If a patient is able to go through induction therapy with nivo-ipi, because ultimately I want to cure that patient, give them the opportunity, the best chance of curing them. So that best chance is with nivo-ipi. And if they have disease progression through nivo-ipi, I think then, as Hans mentioned, the treatment, at least for now, with the current available approved regimens or therapies, will be palliative, will be treating them until we have such a impressive second or third line, a novel agent, novel therapy that could produce a CR that's durable. So for the vast majority of patients, I'm looking to give them nivo-ipi. Now, just interesting to talk about the favorable risk, since it was brought up by both Katy and Hans. Initially, and this is going back to the publication of David McDermott et al. From a randomized phase 2 trial with atezolizumab plus bevacizumab versus sunitinib. The molecular analysis of those tumors that we call by IMDC favorable risk, showed high angiogenesis. And the thought back then, we're talking about 5-6 years ago, was that those patients with favorable risk have angiogenesis-driven disease, so therefore they should be treated with TKI, and they're unlikely to respond well to immune checkpoint therapy, like a dual anti-PD-1 and anti-CTLA-4. However, the 8-year follow-up from Checkmate 214 showed us that those patients can achieve a CR, and the CR rate was 13%. And those patients now, with 8 years median follow-up, there is a flip of the favorable risk in that the duration of response is double with nivo-ipi compared to sunitinib. And the survival now, the hazard ratio, which was initially at primary analysis back in 2017, was 1.45, now is 0.82. So that favorable group, which was exploratory in nature in the Checkmate 214, now is looking like it's converting to where nivo-ipi is producing the latest, more desirable effect.
Yeah, no, thank you so much for sharing. I think I agree with all of my colleagues here that, those favorable risk patients, they by definition, they're the ones that are asymptomatic, they're doing well, they've got low burden disease, they've had their kidney removed, they're progressing. And for the majority of them, you will get another shot. You will get another shot to potentially give them a TKI. And so I think it's really nice to see this data come to light.